And we've heard what you do, but why do you do it? So in other words, when you give chemotherapy, John, are you saying, I really want to surgically convert, I want to make sure I get local control, or are you thinking, I am going to improve survival with this patient? And how do you approach that, right? Because that's a message we give the patient, but we can also discuss our thought process of why we put patients through what we put. And I'll ask each of you that same question. So.
Yeah, so in medicine, as is always the case, this is a shared decision between us and the patient. Our role is to share with them our experience and also our understanding of the published literature. And so this is the approach that I take, and in general. And so a patient with as you mentioned, a 10 centimeter high-grade pleomorphic sarcoma has a substantial probability of dying from that sarcoma. And it's generally unacceptable to most of the patients in my practice. So I discuss approaches to minimize the probability of metastasis and death. And so the data that we use are what we think are the most reliable data, and that is the large Italian study where patients received radiation and resection and were randomized to chemotherapy versus no chemotherapy. And then the same meta-analysis was updated in 2008 and clearly showed an 11% improvement in overall survival, and nearly a 15% improvement in local control in patients with high-grade sarcomas, mostly when doxorubicin and difosfamide particularly are both part of the adjuvant in this setting regimen. And so this is the rationale for our approach.
Yeah, and so Kristen, you'd be the same thing, really focusing on distant relapse-free survival and overall survival with your regimen?
Absolutely, but I also discuss with my patients, every patient is unique, and their goals are unique. So I always ask them, and I tell them the data. I tell them there's an 11% improvement in survival. I tell them what they have to go through, and they decide. We both decide, what's best for that patient, I and the patient. And we're generally more aggressive, just like John's approach, and we usually do a lot of chemotherapy neoadjuvantly, adjuvantly.
Yeah, it's interesting because there are nomograms. There's the Sarculator, which is an app that can give you an idea of distant relapse-free survival. But we do question what is that percentage we can help with the various chemotherapy agents. And Rich, sounds like you would argue the opposite, that we may not know if we're helping, right?
Well, yeah, I mean, so John quoted the meta-analysis from 2008. So that 2008 meta-analysis, importantly, included the original 14 studies from the original meta-analysis and 4 additional studies, but the methodology in which they did the analysis actually didn't mirror the original meta-analysis from the late 1990s. Late 1990s meta-analysis, which did not show a survival benefit, showed a trend, used individualized patient data. The second meta-analysis in 2008 used composite data, and importantly, that second meta-analysis did not include the 450 patients large randomized study that showed no benefit for relapse-free or overall survival.
Yeah. And I do want to point out, too, that about 60% of the pathology was unknown because we had older diagnoses of MFH and unknown within that as well.
And intermediate grade as well.
Intermediate grade. But we also did recently have the Italian study that suggested maybe chemotherapy may have a trend to survival.
So, but to be fair, that they're answering, that the inference from that Italian study, that's not why the study was designed.
Right.
And so they were answering a question that it wasn't powered to ask. But to John and Kristen's point, I completely agree with the idea of patient-shared decision-making and having those informed conversations. And at least at our institution, our patients will say, if you can't guarantee me that chemotherapy is going to provide me a benefit, many of my patients won't do it.
But it sounds like, chemotherapy aside, the consensus is clearly local control, right? So the importance of making sure that margins are clear, whether or not you need a re-resection, real thoughts about radiation, right, to consolidate, especially with higher grade, deeper lesions. And these are the types of discussions that we have with our patients about the need of chemotherapy. And aptly so, there is going to be input from the DMT. If the surgeon comes back and says, we need a little help, or we don't have a window, right, that may also affect what we're saying. But what about a patient that comes in with clearly local advanced disease, a large pelvic lesion, may need a hemipelvectomy if resectable? Is there consensus in approaching that patient?
I imagine not. And there's a lot of factors that come into it, right?
Yeah.
And so clearly, chemotherapy at that point makes more sense to see how they respond, because what you're trying to do is find out what's the biology of this tumor. If it blows right through chemotherapy, then it doesn't make sense to do a massive surgery that's going to be highly morbid and put them through something when, 3 months down the road, after they finally get out of the hospital from their huge surgery, they now have metastatic disease. What have you gained them? And those are the ones where I feel like the patient and I feel most burned about, well, should we have done that big surgery? And so I think finding out what the biology is going to behave like, how responsive it's going to be. If they have a dramatic response, then yeah, maybe it's worth doing a larger resection. It may still recur, particularly in such a high-risk area. Yeah. But if they want to try for giving the benefit of the doubt of getting effective therapy, we should try that out.
Yeah. Rich, do you agree? I mean, is that what patients you use chemo and
I think that's a reasonable
multimodality therapy? And
yeah, so I mean, you can't cure a patient without surgery. And so if you're dealing with disease that's locally advanced or that would preclude the ability to do surgery, or the surgery would be particularly morbid, then I think in those situations you should use everything at your disposal to try to give the patient a favorable outcome.
Yeah.
That's a different scenario than the patient in whom it's clearly more easily resectable.
And is there consensus in what you would use in that situation? I mean, Jonathan, I know you're going to say AIM, right?
Right.
Yeah. I agree with John.
I would
Definitely
too.
AIM.
Right?
Need
If you want a
everything.
response, you give AIM.
Yeah.
But I think as important, if not more important than when to do something, is when not to do something.
Right.
And taking going away from sarcomas, but more into desmoids, not touching it up front may be better than going through a massive surgery. And we see a lot of that where probably someone should not have undergone something that they went through. Yeah. Because it probably is not beneficial to them, or maybe even harmful to them.
Yep, I agree. And I'm a big fan of AIM, especially when I need quick palliation for symptoms, or if we're really trying to surgically convert. I do think that's our best regimen if the patient can tolerate it to get things to shrink.
Yeah, so I would have a couple of comments. And supporting the use of doxorubicin plus ifosfamide is the randomized study by Ian Judson. And it's been published now, but previously presented at ASCO. And it clearly showed a doubling in response rate for the patients that were randomized to doxorubicin plus ifosfamide, and a significant prolongation for progression-free survival by about 3 months, with also a trend towards an improvement in overall survival. So I thought that was pertinent to this conversation. And then also the comment about desmoid tumor, I think opens a whole new can of worms. It's a different tumor.
Exactly.
And we don't resect our surgeons generally don't resect the desmoid tumors, particularly if they're infiltrating, very small ones maybe. But the data on the in the pazopanib study that was presented at ASCO this year was fascinating, because not only is it effective, but we also, and sorafenib is effective also, we know, with about almost a 40% response rate in a disease where response rates are rare. But there was also approximately a 20% spontaneous regression rate for the patients that were randomized to placebo. Yeah. And we all see these spontaneous regressions, but that was a little higher than I expected.
Yeah. No, it's true. It's true, and it shows the complexity of the disease. And we also think about when we engage our community oncologists, what care is done at the tertiary care center, what care is done in the community, and how we interface. And these are just complicated patients. We're using intense chemotherapy regimens. We need to maintain intensity. We need to keep people on track. And so having that discussion also with their local oncologist is critical.